Hi, everyone. Welcome to Airflow Health's webinar on why addressing sleep health in women matters. We're going to wait just another 30 to 60 seconds but to let people join the conference, and then we'll get things kicked off right away. In the meantime, please feel free to, in the chat, introduce yourselves, say where you're from, what you're interested in learning today, and we will be happy to incorporate that as we go along. I'm really looking forward to this discussion, and we'll get started in just a little while, so stand by. All right. Thanks, everybody, for joining us. Really happy to have you here with us for this new exciting Airflow Health webinar, which is going to be on why addressing sleep health in women matters. We've assembled an outstanding panel. Really looking forward to getting into the discussion, and we will have questions and answers at the end. So please, if you have Q&A for us, please feel free to use the Q&A button on your Zoom control. If you're watching this in a recorded fashion, there will be information about how you can reach out to us and contact us if you have further questions after you viewed the webinar. So let's jump in. Just a couple of housekeeping things. Welcome to Airflow Advantage Being the Flow webinar series. This is one in a series that we do approximately on a monthly basis on a variety of topics, really relevant to thinking about how do we enhance the use of durable medical equipment so that health plans and their members get the most value. Whether it's today we're talking about sleep devices and PAP devices and treating sleep apnea with a special focus on women, but we often talk about topics like breastfeeding, diabetes, incontinence, and other things that are relevant to durable medical equipment or DME management. Last time we had a great discussion of breastfeeding and breastfeeding support and addressing disparities and behavioral health issues related to breastfeeding in the postpartum period as well. So strongly encourage everyone to visit our archive and take a look at the webinars that we've been doing now for a year. So we have a whole bunch of them there, great content, and still very relevant to what the challenges that health plans and members face today. And if you have questions, please submit them. You can use chat or Q&A, whichever one you feel comfortable with. We will be monitoring them throughout, and we'll have time at the end for questions and answers. So let me introduce very briefly our panel. We will be providing more detailed biographical information. You'll get a link after the webinar, and we'll have more information about our outstanding panelists. Let me briefly tell you a little bit about who they are. So today we have Dr. Carlera Weiss with us. She is a scientific advisor to Airflow Sleep, an expert in sleep and a researcher in this area as well. We also have Dr. Andrea Matsumura, who's an internal medicine physician who specializes in sleep, very knowledgeable, especially in the area of women and sleep apnea and women and sleep disorders more broadly. Really excited to hear what she has to say as well. And Steve Plensler is with us from Evernorth, where he is a product management principal and sleep product owner in Evernorth home-based care. He also has a background in sleep management, which he's been doing for a long time, and brings amazing experience, both as a clinician who's worked with people with sleep challenges and also as someone who works on the payer side to help organize sleep benefits. So great panel, really excited to get into the discussion. And it really is important for us to address sleep health in women. It matters a lot for obvious reasons. And let's jump right into one of the big reasons, which is that 1 in 4 women are at high risk for sleep apnea, and yet 9 out of 10 of them don't really know about it and are undiagnosed. Even that 10%, not all of them may be accurately or consistently or completely treated. And so today's webinar, really, we're going to talk about how do we address the special and specific needs of women when it comes to sleep, and specifically sleep apnea, and everything from how do we think about the symptoms and presentation to the diagnosis to the management to how do health plans provide coverage and what are the benefits that women are entitled to, and what do we need to do, if anything, to make sure that women get access to the treatments that they need. So let's jump right in. First question for our panel, is sleep apnea a different disease in women than it is in men? I'll turn it over to our experts. Andrea, share with us your thoughts about what is the nature of sleep apnea in women and does it differ from men?
Yeah. So, sleep apnea definitely does present differently in women than it does in men. So, women tend to have disrupted sleep. They may have fragmentation of sleep. They might just generally feel more fatigued. They don't generally have the big bad snoring, apneas, all of those kinds of things. And in turn, when women present with sleep apnea diagnostically on tests, they tend to have more arousals than oxygen desaturations, which is one of the ways that we score and interpret sleep studies.
So, um, Carlia, question for you then. The data here show that as we get older, the prevalence tends to go up. There's still a disparity in the difference of the prevalence of sleep apnea in men versus women by age group. I know you have an interest in caring for older adults. Why is that? Why do we see this increase as people get older?
So that's a very important point for the research perspective, because we see that those changes in the prevalence and the symptoms for obstructive sleep apnea in women as they get older are likely sex hormone dependent. So postmenopausal women, they are more likely to have obstructive sleep apnea due to the changes in estradiol and progesterone. Also, we see changes in the anatomical of the upper way for older women, as well as we see those changes during different lifespan for women. So pregnancy, pre and post partum, postmenopausal, those all have a difference for women. And that is correlated to have a high risk of obstructive sleep apnea. And as Andrea said, the symptoms are not that typical symptoms that we see on textbook for obstructive sleep apnea.
I would say, generally speaking, what I tell people is that we get floppier on the inside, just like we do on the outside as we age.
As a geriatrician, in my professional opinion, I would completely agree with that. Human being
Very scientific.
molecularly challenged, I totally get that as well. There are aging related changes that happen to all of us if we're lucky to be aging. And I guess one of the questions then is, you mentioned, Andrea, that the differences in desaturation and in the snoring. Why is it, are women's airways different, or is it neurologic? I know that obviously the hormones that you mentioned, Carly, have an impact, but what explains this difference between men and women? Do we really know, or is it still something that's being worked out?
Well, I bet you Carliera knows more about this than I do, but I'll take a stab at it. Generally speaking, estrogen and progesterone, the way that they bathe and how the tissues are supported with those hormones, there is a change in the tone. So it's really in that postmenopausal state that there is this heightened awareness. There should be a heightened awareness when women come in with symptoms. And frankly, we should be screening people. That's a whole nother section that we could talk about for a long time. But there isn't really a great screening tool. So the tools that we have, we should be really using them very frequently when people come in. And generally speaking, the first thing, if people say they have trouble sleeping, the last thing I want to see anybody do is prescribe a sleep aid. You really need to start digging deeper to find out, well, why is somebody having trouble sleeping? Because what I have seen is that somebody has this long delay in diagnosis because they presented with, I'm having trouble sleeping, and the reflex, because frankly speaking, clinicians don't have enough time most of the time to really dive deep. They are prescribed a sleep aid, and then they're on that for years until somebody says, hey, you've been on this for a long time and you need more. What's going on here?
Really good point. In fact, that leads to our next question. I think we kind of talked about this, but what does lead to these differences and how are they reflected? And the symptoms are different here. Can you talk about sort of the mood and neurobehavioral performance? What does that mean? And how should we, when someone comes in and says, I'm sleepy, obviously we don't reach for the sleeping aid right away, although many people buy stuff over the counter, so it may beat you to the punch, even if you try to have that discussion. But how does it affect mood? How does it affect energy levels? What are the impacts of sleep apnea specifically in women?
So I can start describing this a little bit. So what we see from the research perspective is that since the typical symptoms for women that have obstructive sleep apnea are not the classical ones with snoring, we see more presentation of mood disturbances and daytime fatigue and more depressive symptoms as well. And interesting also is the insomnia that is also associated with obstructive sleep apnea in women. So when they look for treatment, describing the symptoms of fatigue, depressive symptoms, and insomnia may not ring the bell for a good screening for obstructive sleep apnea. We also see that having those sex hormone dependent decline postmenopausal and weight gain, and just have a different stability for the upper airways and the respiratory function also affecting them. So as Andrea was saying, we need to be more aware of those symptoms not being the classic ones and really understand that those are sex difference for them.
So kind of going along and piggybacking on what Carlera just said, going back to the diagnostic criteria in testing women, they tend to have more insomnia. And I say that in quotes because it's really these arousals that are waking women all the way up. That tends to be a little bit more common in women than in men. Men typically will have significant oxygen desaturations, which is part of the criteria for deeming something normal versus abnormal. Whereas women will have more of an arousal, which is also part of the criteria, but not captured on home sleep study testing. And that's kind of a sticky point when we think about the first pass testing that insurances cover.
So are home sleep tests not as effective in diagnosing? Steve, maybe you want to address that?
No, I was going to address the guidelines from a health plan standpoint. I think Andrea is right that the guidelines, the way they live and breathe today, brought about by the ASM, CMS, and others, are relatively standard and set. Sorry.
So who's the ASM and CMS, just to make sure?
The American Academy of Sleep Medicine, sorry, and then CMS is Medicare, the payer. So they set guidelines that everybody on the phone and all the health plans live by, but those aren't fluid, they're very static. So in some sense, in women, an attended study would be more appropriate than a home study for a variety of reasons, which we'll get into later, but there can be an impact, yeah.
I think somebody put in the chat, what is home sleep testing versus in-lab sleep testing? And you're right. That person said, home sleep testing is a portable device that you're going to be using in your home. And it does not have all the attachments that an in-lab sleep study provides. And an in-lab study means you're testing in a sleep center, and you have, there are different attachments that are used. Some of them are similar, but it's not as sensitive and specific as in-lab. Home testing is not as sensitive and specific as your in-lab testing is.
So basically, in-home is looking at things like your heart rate and pulse and your oxygen level in your blood. It's also measuring sort of your respirations and testing the flow of air in your nose. But when you go in the lab, we have to sleep in a strange bed and someone's watching you. You have all these lots of things hooked up to you that include all of those things, plus a lot more focus on the neurologic, right? So the arousals, for example, those are changes in brain waves, how we measure those. You don't get that at all at home. Is that right?
Yeah.
Generally speaking, no, you don't, unless in a rare case, like a type 2 home sleep test would have EEG, but no. So to correct, but go back, yes, a home study is specifically for folks that are at moderate to high risk of severe moderate to severe obstructive sleep apnea. So if you're in the more mild to moderate category, which many women are, the home study might not be as good. But there are a lot of things going back and forth really about even some of the thoughts in the chat. But I think in my experience of running sleep centers and all that, some people, they'd rather be in a sleep center. Some people, they'd rather be at home, and everybody's different. It's interesting. But for someone that's relatively low hanging fruit, a middle-aged, overweight, snoring male, a home study is great. But others that go outside of that, a home study has limitations. But insurance plans tend to go to home studies first because they're cheaper. But I think that that's somewhat short-sighted, and we'll talk about that more as we go on.
Yeah, so two things I want to add to that, to what Steve said, is that I would put a plug in that if a person has a negative home study, you really need to take a look at the entire picture and maybe not stop there. I find that a lot of people stopped at the negative home study, and there are plenty of positives, and I don't have the exact data on that. It's actually very hard to find online. Maybe Steve does have some of that data, or Carlera has that data, but I find that a lot of women end up becoming positive in an in-lab setting. And then the second piece is that I want to make it really clear that insurance companies have pushed us into saying that you get an option. And I really like to educate my patients and other clinicians that it's not, I feel, like a home study versus an in-lab study. It's more of a clinical indication of what is needed.
Right.
So
Right.
it's kind of like saying, well, I'd rather get an MRI than a CAT scan, but there's clinical indications for which one is better for what condition you have. So I
Right.
get that question a lot from people. Well, my doctor said, or my PCP said I could get a home study, and I will have to explain to them, well, because you have X, Y, or Z, we really need to do an in-lab study.
That makes sense. And
Yeah.
go ahead, Steve.
Yeah. One last thought, but Andrea is right. In any medical situation, what you hear and see oftentimes from primary docs and online, they're not the specialist. If you have a cardiac problem, you go to a cardiologist. If you have a lung problem, you go to a pulmonologist. If you have a sleep problem, you should go to a sleep doctor. They can take much better care of the situation. And like Andrea said, we need patients to get what they need, not what someone thinks they need. So getting these people into the right hands, the right professionals to say, well, the home study sounds lovely, but that's really not what we should do. What we should do is this. So correct.
And it's also the case if you ask two physicians, you get three opinions in some cases. So there's always medicine is the practice of medicine, and there's an art to it. And it really does speak to using clinical judgment. And that's true for clinicians of all kinds, not just physicians. It really does come from the experience you have working with a particular population that then can inform you about how to have a discussion with someone about their particular case. I think that's a challenge we have across healthcare today, is it's easy to read stuff online. The hard part is figuring out, how does that apply to me? And I think one of the major roles of the sleep clinicians, whether it's a physician or whoever, is to help people understand, you may have read that online, but your case is different because of, like you said, Andre, A, B, C, or you're not a typical person, or you are a typical person, a home sleep test is perfect for you. We're going to go ahead and do that, right? So it's really making sure that people understand that we have to always look at their general rules, and then there's you. And you have to have people who help you translate risks, benefits, alternatives, costs, all of that, from going from the general online world or what your primary care doctor said or whatever, to really understanding what the choices mean to you. So let's move ahead. So we talked about a little bit about the diagnosis being a little bit different in the in-home versus in-facility or in-lab sleep testing. So there is an increased rate now of women presenting to sleep clinics. I'm just curious, what's happening with that? Are there technologies driving this increase in presentation? What are you guys seeing?
So I think there's just heightened awareness, as somebody on the panel said, I think it might have been Steve. Everybody's talking about sleep. Sleep is in the media. It's all over the place. So it's gotten recognition that it's important. There's also, data that's come out that, if you're not getting enough sleep, that might be, a risk for memory loss, dementia, higher rates of cancer if you're chronically sleep deprived in certain cancers. So all this media attention around sleep and getting enough sleep. One of the distinctions I like to make, though, is that there are a number of different sleep disorders. Sleep apnea is abnormal breathing in sleep. It is not abnormal sleep. However, once we correct abnormal breathing, then your sleep does change, hopefully. Not everybody has that happen. One of my analogies is high blood pressure. You don't walk around saying, oh my gosh, I have high blood pressure, right? Typically, you go to the doctor and they say, hey, your blood pressure's high. And we have data that says you might be at increased risk for heart attacks and strokes. And so too with abnormal breathing and sleep.
It is a discussion, right? It's a process of translating the interpretation of what it means to have sleep apnea, and moderate or mild or severe, and what does that mean, and how does it impact your life? Some people have daytime sleepiness, some have the neurobehavioral changes and depression and the insomnia, things we talked about before. It's really making sure that the person understands. And today we're talking about the important differences between women and men, but ultimately, whether you're a man or a woman, it comes down to you as an individual, and the skill of the clinician is translating and helping offer the best choices for you. Let me move ahead. Next slide. So here we see some interesting information, and this kind of came up a little while ago in terms of presenting symptoms. Women have insomnia, restless legs, depression, nightmares, palpitations, hallucinations. These are typical. Obviously, women also have, some of them have snoring and daytime sleepiness. Men will have some of these symptoms, but they tend to have more typically the snoring, daytime sleepiness. What does that mean then when you do these sleep tests? We talked already about in-home versus in-lab sleep testing, but if these symptoms present differently, should the testing be different? Should the screening be different? What's the best way about understanding? Should everybody be screened for once a year? What are the recommendations in terms of guidelines? And Steve, you said the guidelines are static. Are things moving here, or should they move? I'm just curious to know kind of where are we with understanding how to interpret these symptoms and how to actually make the diagnosis.
Yeah, I'd say two things. One, the guidelines, if we really think about what health plans and their vendor partners do in terms of approving home studies or attended studies, the guidelines generally filter down from CMS, which is Medicare. CMS has NCDs, LCDs that are fed by the AASM and others, but the NCDs and LCDs are old. They're 10, 15 years old. And in my opinion, they have not kept up with the times. So we need to get better at.
I'm sorry, can you explain just what is the difference between an LCD and an NCD, just to make sure, and local decision versus national?
Hopefully, DME certainly should go and know these are, but national coverage determinations and local coverage determinations are ways CMS determines what they will or will not cover. Ultimately, usually the local coverage determination is more appropriate for given areas based on who their overarching management company is, but that dictates how many units of CPAP are paid for, how much are paid, CPAP masks, sleep studies, oxygen, whatever. So that's an issue. And then the second piece, I think, was back to Andrea's point about clinical judgment. A female that comes in and has insomnia, restless legs, and everything on the screen, but is more obese or is more likely to have sleep apnea, frankly, in a home study may be more appropriate. But if they're not as obese or they don't have the presentation that a home study would be more appropriate, then maybe an attended study would be more appropriate. We don't have that delineation and guidelines yet between men and women, not that I'm aware of.
Yes, and just to add a little bit to that, as we said in the beginning, the symptoms in women are non-specific compared to the typical ones that we consider like snoring and daytime sleepiness. So the screening tools that we have available now may not be able to capture those the sensitive of the different symptoms that women may have. And the second thing is that looking at different ethnicities, we have differences in anatomy and also in some cultural beliefs as well that may be in the way for making a proper diagnosis and interpretation of the symptoms. So for example, African Americans and Asian with a different anatomy for the upper airways, for the nose, and for the neck, and that can affect also the breathing pattern and the breathing instability, especially postmenopausal. So those things should be taken in consideration as well when we are looking at the symptoms and how to make a good assessment and screening for them.
Interesting. So, Steve, I think what you just said it before is that there aren't separate guidelines for men or for women. And it sounds like there are differences also related to ethnic characteristics. The guidelines account for that, or men, women, different ethnicities. Is that part of it, or does it just kind of one size fits all? And if you're not in the typical
That's
male,
one size fits man.
Yeah. Woo man and man, right? Yeah. No, yeah, it's sort of one size fits all. And I just think we as a field, and I say we because I'm part of the field too, haven't done a good enough job really digging into research, et cetera, to support what the guidelines should say. We're just not there yet, unfortunately.
and what's happening? I mean, are we seeing more studies that focus on the differences between men and women or appreciate the difference in ethnicities? There's been a big focus on addressing the problems we have with equitable access to care in the US already. Is that impacting sleep medicine as well? Maybe let's take the gender question first. I mean, do we have enough research to really understand not just the differences in symptoms, which are based on experience and people reporting to clinics, but do we really know what the differences are in terms of the best treatments? Like, do we know PAP devices work just as well in women as they do in men?
The research is growing on this area for gender first. So I'll say in the past 5 years or so, we see more studies looking at the adherence to PAP treatment and also the outcomes of PAP treatment between women and men. So it's growing, the evidence is growing for the research on that, but we definitely have more room to more detail, including the ethnicity as part of those assessments too. So I think it's to be hopeful that the field is growing and more people are getting into the interest to look at the sex difference and the gender in the ethnicity differences as well. The preliminary research that we have on this area shows that once we see adherence to the PAP treatment, both men and women benefit from that, but it needs to be more investigation on gender-specific PAP treatment or how the titration should go for men and women, especially postmenopausal women.
Great. And just to be clear, so PAP is positive airway pressure. These are the devices you see that help people keep their airways open when they have sleep apnea so they don't have these problems with the arousals, and then not arousals, but they don't stop breathing while they're asleep. And so much better for their blood pressure, better for their hearts, and for diabetes management, and a lot of other things. Surprisingly, it turns out that sleep affects all of these symptoms, all of these systems in our body, and not just the airways or the brain, but it's actually all connected. I am curious though, Andrea, do you feel also that there are adequate resources to do research into questions related to treatment efficacy in men and women, looking at diagnoses, screening, the things that we've been talking about? Or do we need more?
I'll take a step. So one of the things, just to add to what you said, I always say that sleep is the juggernaut for everything else to fall into place in your life. So that, without a doubt, it affects every other organ in your body if you're not sleeping well for whatever reason. Now, in terms of enough support out there for research, I'd say it's slowly growing. I don't think it's caught up or it's fast enough. We do need more research out there around gender differences, ethnicity, race differences, to, focus on race-conscious decision-making versus what we have done in the past. And, medicine is fraught with all of these inadequacies. So the piece here around really women focusing on the gender differences, there isn't a lot. There is up and coming data, which I'm pleasantly surprised by, around CPAP versus other devices, maybe an oral appliance that might be used for the treatment of sleep apnea. However, there's all these other inherent hurdles that patients need to figure out. And, if we're speaking to, this is a DME company, we all know it can be cost prohibitive even just to treat sleep apnea. And for whatever reason, this is one of the only things that, insurances can take back if you don't use the device enough. Somebody in the conversation said, how do we get people in compliance? That's all education, but these types of things are not paid for. So spending time educating patients on really understanding, why am I treating what I'm treating? Like, why is this important? That's really not being acknowledged at this point in time. And, there is some data out there showing that women may have better adherence to oral appliance treatment. An oral appliance or a mandibular advancement device is used to pull the lower jaw in millimeters forward to open up the airway. And that's only in a select population, because again, people see a lot of things online, but it's really about the anatomy, because sometimes that's just not going to work. You need positive airway pressure to open up that airway. So I'll stop there. I'm sure other people have comments to make around this. It's a big topic.
And just one other question. So
Yeah.
are there differences in PAP use and PAP adherence between men and women? Like, have we done those studies to see, like you mentioned that women may do better with oral appliance adherence, but do we know when we compare 100 men versus 100 women, are the percentages going to be similar in terms of PAP adherence or not?
I'd say there are barriers. Maybe Carlera has some data around that, but there are barriers because, let's face it, DME companies, people who make masks, they're making them to fit men's faces. They're not really making them to fit women's faces. You can make it pink or purple, but it still was initially made to fit a man's face. And so women's faces are smaller. So there's a barrier there. Plus, there's this stigma, like it's this big device. I had a patient tell me this was the best birth control I ever prescribed for them.
Mm-hmm. Yeah.
Because.
Yeah.
Go ahead.
I think technology has gotten better. I remember years ago, I started as a sleep technologist a long time ago, and really there was two masks, two machines, which one do you want? That's come a long way. And I think in the last 10 or 20 years, you're right, there are now women-specific masks, but not nearly as many probably as we need. I think the other piece of that is the whole, in terms of technology, AI or designing specifically to a patient's face. We're going to get there. We might have a laser or one of those printers with a 3D printer to make it. We're not there yet, but I think the issue becomes really the awareness, making people aware every patient's different. I mean, sleep is a really personal thing, just like all the healthcare, but personalizing the approach for every patient. Some patient, I saw one study, is maybe not the place to say it, but the study looked at having CPAP as the last resort, meaning try everything else first. Let's make sure that there's nothing surgically that needs to be done, that an oral appliance doesn't work, that whatever else tries first, and then you do CPAP. At that point, you've gotten to the correct phenotype of that person is a CPAP person. Not everybody's a CPAP person. Not everybody's going to respond. Not everybody can do it. But the more we can tailor the treatment to that patient, he or she's going to be much more successful if an oral appliance is correct, or CPAP, or a BiPAP, or a nasal pillows, or a full, whatever the situation is, tailoring it to that patient is important. I mean, we all know from we have got lots of stories from sleep centers. Remember big, giant, burly men coming in to have a sleep study carrying their teddy bear. We're all weird about sleep, man. So anyway.
You know, I would add to that, as we're talking about CPAP, one of the things I try to do is demystify it. You know, the fact of the
Yeah.
matter is that it's one of the easiest things I can prescribe. I'm literally prescribing air for people, room air. It's just flowing through a machine. That's
Right.
pretty low on the invasive levels. So when I think about treatment, again, try to normalize it for people that this is just a mechanism for room air that's forced. It's just simple as can be, and it has way less side effects than any medication you could take, and certainly way less side effects than any procedure or surgery that has lower success rates, frankly.
Yep.
All really good points. So just to kind of close this part up, and I want to get some questions. There have been some questions in the chat. It'd be helpful to discuss. Two questions. The last question was sort of about, as we look ahead, what do we think? But before we get there, what about the coverage policies? So we've heard that they're one size fit all. They need to be more specific. We've heard that they're not really addressing the differences in people, male, female, ethnically related. We've heard that there's ongoing research, slowly growing research, which should help us understand how to set up these guidelines. What's happening? Like, Steve, do you see the American Academy of Sleep Medicine, or CMS, actively reviewing their guidelines? And do they have plan to put out new guidelines next year or the year after? Usually guidelines are reviewed on a regular basis and updated. If that happens, we then expect health plans to respond. Is that happening now? Is there a pipeline of potential changes coming?
Yeah, I know the American Academy of Sleep Medicine is always looking at their guidelines, always updating, or always having practice parameters and work groups. I think that doesn't translate nearly fast enough, and CMS is even painfully slower. But I think at the end of the day, the way PAP policies read today, there's a pretty wide open spectrum. So just off the top of my head, I don't have it in front of me. CMS, even health plan criteria, if you have at least mild sleep apnea and you have other symptoms, there's ways to get PAP covered. So I think in terms of coverage, as long as the health plan covers PAP, I've run into health plans that don't, just it's interesting. But as long as they cover and the patient meets the guidelines, PAP is covered. But we also know, like we said before, adherence to therapy is highly dependent on lots of factors. One of the factors is, generally speaking, the more severe the sleep apnea, the more compliant you are. Again, it's relatively simple to think. Like Andrea said, you're prescribing air, you're blowing air into somebody that hasn't breathed in years. Literally, they fall asleep, they don't breathe. So now they're breathing, they're like, woo, it's party time. So, but as you get to milder forms of sleep apnea, unless they have significant daytime sequelae or whatever, compliance decreases. But again, there's a lot of hand holding. There's a lot of that needs to be. I mean, I think the payment models, the coverage guidelines, what I would like to see is some kind of coverage. There used to be coverage for supporting PAP use. In other words, there used to be a code for that. I think it was A9279. It went away. The idea is these PAP machines have tons of technology. They download data that nobody else in medicine can dream of. But we don't do much with it other than how many hours did you use it last night? Well, what was your flow limitations last night? Did you have leak? What was your flow? There's a lot of data that comes out. We don't do anything with it. So I would love to see something in that lane, but long story, I think change will come, but it's sort of painfully slow, in my opinion.
We don't do anything with it that is paid for. That's the problem. But we do a
Right.
lot of unpaid care.
For sure. Absolutely.
And just to add to this, thinking about specifically about women, right? when we look at compliance to CPAP from the research lens, what we see, although there's very limited data looking specific to this, but what do we see that the compliance for women specifically is not only related to the titration and to access to the PAP supplies, but also about the caregiver roles that they have for their families. So either they have child care or other caregiver roles for a relative or an aging parent or a partner that also impacts their ability to comply to CPAP. And in combination to that, because severe OSA is not as prevalent in women that is in men, as we see in the slide here showing that mild OSA for women, because they don't have a severe breathing disturbances, they may not adhere to CPAP as well as a person with a severe OSA would. So again, needs to be tailored, the treatment needs to be tailored, and also take in consideration all those different aspects that Andrea said, like it's a different type of care that we cannot charge for, but it's very necessary to make this compliance more accessible and a reality that impacts their quality of sleep and quality of life too.
Very, very interesting. Unfortunately, our time is speeding by, and I want to jump into some questions from the chat, make sure we've covered everything. Before we get there, though, I'm going to ask the panelists to tell us, as you look ahead, given that we've identified some challenges, what gives you hope when it comes to changes that will improve care of women, specifically with sleep apnea, and what's keeping you up at night? And Carlera, why don't we start with you?
Great. So what is giving me hope right now is seeing the diverse workforce in the research in the clinical setting that is driving the changes to look more into gender specific, into racial ethnicity specific questions, and making this more accessible and more equitable to everyone. So that's giving me a lot of hope. And what keeps up me at night, talking about childcare, I have a little one, so that keeps me up at night. But really thinking about the social determinants of health and how that impacts the access to healthcare. This is still keeping me up at night.
Very good points. Steve, you want to go next?
Yeah, I think the hopeful piece is increasing awareness for sure, and knowledge. I think as we, and it's sort of a long story, but as we move towards what we call value-based care and really having payment models focused on outcomes, the huge glaring hole in that piece, that whole puzzle is a third of our life, which is sleep. Very, and I hope nobody from anywhere I know is on, but it's very missed. It's very overlooked. I mean, how can that 1/3 of your life possibly have a role? And that's also part of my fear. I think the other piece of the fear is health plans are laser focused on saving money and dollars. And so yeah, I'm coming at it from a totally different perspective. And I think we have to have a better understanding of the value of sleep. The value is, in my view, as Andrea said, sleep affects everything. It affects all of your health. So we have to understand better.
Good points. Andrea, bring it home. Tell us what your thoughts are.
Well, I'll just add to what they already amazing, perfect points here. What's giving me hope is that there's more awareness. For instance, these types of forums and seminars, we're educating people, like people are getting out there, and there are more women in, frankly, what I think really has happened is that there are more women in healthcare who are aging, who are saying, oh, wait, this doesn't make sense. Help us. And so there's this big explosion of, hey, we're a different gender. We have different needs and we present differently. And so I think that's really hopeful. What keeps me awake at night is that there's all this awareness, but the action to move on that is moving at a glacial pace. And to what both Steve and Carlera said, it's just not happening fast enough. And, I'm aging and I'm thinking by the time maybe I'm at the end of my bell curve for age is when things are going to start to maybe happen. And I'm, so there's a mix of dismay and hope, I guess, in the sense that it's going to come around. It's just not getting fast enough. And, the issue is that insurance companies play too big of a role in making these types of decisions. And we really need to, we've lost our focus as a country, basically, on how we take care of people on some level because of how insurance has such a strong hold on how they dictate what happens. It started out good, but it's ending is not good. The premise around developing guidelines, is excellent in its theory, but in how it's being practiced now, the pendulum has just swung too far. And that's a whole nother topic.
Yeah.
That is the 64, it used to be $64 million. It doesn't seem like much money anymore, but that is the big question is how do we look beyond cost as a way of managing health? That's really the key question we face. It's not just the health plans, it's the employers who are paying for the coverage, it's the government that has limited funds, it's at every level. And so I think the challenge is to not only focus on, is there a return on investment? I think Steve's point about the impact of PAP is not just dollars and cents. As we've said, it's a third of your life. It affects every aspect of your health. How we demonstrate the value of that is really the tricky area. That's not unique to sleep. It has to do with aging more broadly. It has to do with cardiovascular health. I mean, all of these areas, it's really understanding that health and its impacts that the impacts of financial impacts of health improvements cannot always be measured, and that there are other criteria that are just as valid as financial impacts that may not be getting the attention they deserve. And so I think these are the core debates that are, I do a lot of work with a lot of different areas of healthcare, and these are the same discussions we have all the time. It's how do we bring better value. Value doesn't only equal cost, it also equals quality. Those things are, all three of them are related.
Yeah. I think, go ahead.
Go ahead. Go ahead. I had I'm sorry. You made one comment, Mike, on the comment, and that is employers. Employers do drive an awful lot of healthcare spending, and sleep could really differentiate them, particularly those that have employees that are doing dangerous things like driving or staying awake all night, all those kind of pieces where sleep needs to be maximal. But I think also as companies compete and they need to decrease healthcare dollars, they should think about that third of patient's life for sure. They're missing out.
I think we lose the forest for the trees in that regard. And it comes down to that old adage that we need to be proactive instead of reactive. And, the healthcare is a reactive, it's still in that reactive mode. And we've made attempts to try to move to the proactive, but then I think the pull is that, well, the return on investment, right? So it's hard.
No, for sure.
But it's worth having these discussions. Let's move quickly to the questions. I think there's a number of things that are in the chat we really have addressed all along. Just want to make sure that we've covered most of them. I think, the question about I guess, what's the right path and I guess this is a question for the panel. Given we know that there are these challenges related to barriers for women, barriers for people with different race and ethnicity, barriers with social determinants, people from different socioeconomic strata, what would you advise health plans? Because we understand that there are underserved populations. What would you advise them in terms of thinking through, like, what's the one thing, if you could suggest to them one thing that they could do to help smooth the path, ease access, what would it be?
Yeah, my perspective is, and don't take this as self-serving, but I think either hire sleep specialists or bend to someone that knows sleep well. I mean, in my opinion, health plans have so much to do. DME is an area there's a lot going on. There are thousands of codes, there's millions of pieces for all these different equipment that it's hard for them to understand. And sleep, like I said, how the sleep impacts all of their members' lives, they need to understand it better.
So focus on use of experts in sleep, which I think is really good advice.
Absolutely.
Yep. Andrea, what's your first choice?
I mean, I would agree with that. I was just thinking as Steve said that it'd be really something if we could embed a sleep specialist in almost every like primary care setting. That would
Yeah.
be phenomenal because it would not only help, identify abnormal sleep, or disorders of sleep, but it would also help the whole health. We're talking about whole health, the whole person here.
Right.
And if you can identify a sleep issue, that's going to help regulate blood pressure better. That's going to help regulate blood glucose better. That might reduce pain levels. So it actually has this ripple effect on reducing healthcare costs.
I like what you said. It's the juggernaut, right? You said sleep is it's a can make a positive in many dimensions of your life with one set of simple changes, not simple, but one set of behavior change lead to a lot of positive outcomes.
Yeah.
Earlier, what's your choice to wrap
Sorry
things
to
up?
interrupt. Yeah, but I would add to that, take one step back or further, depending on how you want to look at this, but really get to the community and explain the importance of sleep at the community center, especially for the underserved communities, because as we know, sometimes there's some cultural perspectives of behind not reporting sleep problems, or for example, that you have daytime sleepiness, you're not reporting that because you don't want to be perceived as lazy, depending on the cultural background that the people have. So make sure that the people in the community also understand the importance of sleep, and that they're more likely to signalize to their primary care provider and request assistance for a sleep specialist to understand that that's something that might be wrong with their sleep. So I would add this to what Andrea and Steve said.
Yeah, and I think to expand on that, Carlier, when you think about environmental impacts, underserved communities, noise, pollution, all those factors interrupt, fragment sleep, and you see increases in all kinds of diseases or behavioral problems in those populations because of poor sleep. It could be everything from ADHD to lung disease to what you name it. There's a relationship for all of that.
Well said. With that, we're going to wrap things up. Just a couple of housekeeping things. We will be sending out the link to the webinar, so it's available on demand. Feel free to share that with friends and family if you're think they might be curious about sleep and what we can do to make things better, and specifically about the differences that women have in terms of how they present when they have sleep apnea, and potentially even how even the treatments have not been adequately designed to meet their needs. So lots to share from this webinar. Feel free to do that. We also have a newsletter. Feel free to subscribe to that from Airflow. There will be a brief survey that's distributed. Love to have your feedback there. And you can follow us on social media. Or if you're going to be attending the upcoming AHIP Consumer Digital Health Conference in Nashville between September 24th and 26th, please feel free to ping us. We'll be there. Would love to continue this conversation and really appreciate the excellent conversation we've had. And I personally want to thank each of you for the really valuable information that you've shared today and the thought-provoking reality that there's more to be done and we need to start doing it. So thank you all very, very much, and look forward to talking again soon, I hope. Take care, everybody.
Thanks, everybody.
Thank you so much.
Bye-bye.
Bye-bye.